Appreciate it. Always appreciate the invite, and I'm glad we have a nice casual group here, so it's good. I've had a really rough 24 hours, so I don't even want to. I do need to get it off my chest, but but I won't. I'm not going to talk about it. but anyway, so getting back to the point at hand. I mean, preventing disease progression, right? Because it's sort of a lot of what it's about with endometriosis. And what's the best way to do this, or do we know? And this is something that I'm always interested in myself. And when I prepare lectures, I want it to be a topic that I find interesting, because we always learn when we're preparing. So, but is excision medical therapy? Is it a combination? And especially, when we think about what the future is coming in endometriosis with non-invasive non-invasive diagnosis, really around the corner. It really does become even more of a question about what is the best way we should do this and manage it. Okay, so just my disclosure, nothing to do with this topic. But, again, treatment options, you guys all know, but conservative therapy, medical therapy, surgical excision ablation. So, and especially conservative therapy, do we need to treat at all? Right? We're going to have, if we know someone has a diagnosis of endometriosis based on imaging or one of our, or a test, do we need to treat? Medical therapy, surgical excision ablation of all visible lesions, or surgical treatment followed by medical therapy. That's basically it. And so, when we look at this, and this is how I try to look at my patients is, endometriosis is really, it's focused, and it's a personalized treatment. I mean, we say this about a lot of things, right? It's always personalized. Patients shared decision-making and all those nice words. But with endo, to me, it really is that. And it's, when, I'm going to skip the first one for a minute, but, if it's an infertility patient, if the goal is all about fertility, the question is that patient, should they have surgery, medical therapy, or just proceed with their, assisted reproduction? And obviously, I think without spending too much time on this, right? It's, depending on extended disease, there's more and more where it's, say, in the old, say going back a few years, it used to be, no, just go ahead and do your assisted reproduction. More and more, I think, many of us who do this, we're getting more and more of our patients sent from the fertility doctors who want treatment, or want their patients to be treated. They're doing testing. They're doing biopsies, and they feel a lot of their failures. And again, there's good data on this, that failures are associated to, obviously, endometriosis, and especially there's some really reasonable data specifically on DIE. Pelvic pain, organ involvement, same story, right? There's it's all personalized. The question is, and this is one, and to me, main part of this talk is the asymptomatic patient, or the patients with mild symptoms. Should we be operating on these patients? Should we be, putting them on medical therapy, or maybe should we, or is the answer we do nothing? And finding these answers, evidence-based is a little bit of a challenge, and I'm sure it's not only unique for me. And again, as medical therapy options have expanded, right, especially with the GnRH antagonists, and others, and all the choices for the different progesterone therapies, with LARC, et cetera. There's we get, for many patients, we have reasonable symptom control. The question, though, again, what about disease progression? Because that's what, to me, we can have symptom control with medical therapy, we can have symptom control with surgical therapy, but is there one that's better than the other, from that standpoint? I'm just going to go back a little bit about, just the GnRH antagonists. Very effective in reducing pain, right? So with, up to 75% of patients who are on a higher dose, on the 200 twice a day regimen with good result for pain. But again, does that tell us about disease? Right, it doesn't tell us yet the answer. What about disease progression? A little bit of an unknown. When there's a lot in the adolescent population, and I find it interesting because, again, this is probably one of the more important populations is that certainly we know endometriosis is also present and active in adolescents, and even a significant number of them actually even have can have deep infiltrating endometriosis. But so again, what's the status on disease progression? Based on what therapy's done, and when you look at the evidence, it's actually all over the place. Where there is some that says there's no progression, some says there is progression. There's so it really is. There's not a with treatment. So it's always something that's still, I'd say there's a question mark. But one of the things that I always think about when I'm thinking about my approach is, when we think about all the different the pathophysiology on, today, the more current ideas about where does this all come from. It sort of almost leads you to believe that, why surgical therapy alone would be the answer for preventing disease progression. And if anything, it's more to the sort of say, hey, we got to treat this more from a medical, when we're talking about prevention. And so one of the things, one of the things that I really hadn't thought about much is, there's more talk about, I'm going to see in one of the next studies, but, this is the genetic epigenetic theory, but there's obviously we have still multiple theories about, development of endometriosis. But I forgot this whole microbiome theory that's out there also, that it's also not, it's also related to, our, microorganisms as well. And when you think about that, and, again, it leads to the whole idea that clearly, if we're really talking about disease progression prevention, it's got to involve some suppression. I mean, it just from our own, philosophy and belief and how this whole thing starts, just doesn't make sense that surgery alone is the answer. Not that surgery is wrong, obviously for symptom control and the other pieces. It's just that I don't think alone is necessarily the answer. This is old, but I don't know about you. I'm getting a lot of referrals from infertility docs with elevated CA-125s. I don't know if anybody else is getting that. I hate that. Okay, but there, for whatever reason, I find in this neck of the world, they're doing a lot of CA-125s and sort of using that as, let's say, a reason for treatment, or at least to say, hey, this patient who was treated needs additional treatment or whatever. And so I was looking back, some of the, this one's not that old, but basically, we know it, CA-125 absolutely is elevated in our patients, especially with significant endo and adeno in particular, the adeno patients also. And they do improve with surgery, which is excellent. But it's the question is, what is the role of monitoring and everything? And there, I'm going to say again, also very equivocal data, but there's definitely seems to be some, role in the monitoring. Again, I don't know how it's, again, correlating to a clinical, like in a clinical space, like if saying from, hey, if your CA-125 is lower, you're going to have a higher success rate in getting in conceiving and all those things. I don't necessarily have that answer, but this is even older study, but surgical treatment does reduce levels. Progesterone didn't, but this is in the days of a lot of danazol use, but danazol did lower the levels too. But, the question is, and also GnRH agonists have been shown to decrease CA-125 levels. But, so in general, but they do rise again. And this is where I think our approach with patients, if we're talking about disease prevention or to preventing progression, is really it's chronic treatment. It just really, it's chronic suppression. It's not, yeah, we can play around with it. It could be 6 months of this, it could be 2 years of this, or whatever. But I think it's going to come down to that, we need to have patients who really chronically suppressed. Same thing we see, there's data on, some of, let's say, the naturopathic ways, quercetin and others all support, that there's been studies showing decreased size of lesions with some of these things. So, again, could be a combination of things. It's not one answer to any of this, but certainly, there's definitely some, evidence all around. And I'm going to show this a couple others. This is the one, some that I learned because it's talking about the microbiome, but antibiotic therapy this is in the mice population, but decreased progression using antibiotics, using Flagyl. Really, I just found it interesting. And again, other, targeting other receptors, again, also in a model, to show that with, intervention, we're showing actual, prevention of progression of disease. And I think that's what it, comes down to. So like, I like to look at it and separate it out and say, we have the patients who it's all about their symptoms, but then there's a significant subgroup, especially the younger patient, it's all about, preventing disease progression. This was an interesting study about, surgery and disease progression. Now, these were all patients who were re-opt. Okay, so the subset of patients were, it's sort of a skewed population because these are all patients who had re-ops. And, again, medium time and these were patients who just had excision, excision surgery. But, there was progression in 66% of the patients, even with mild endo, and even 39% of those with endometriomas, progressed also. So, just one more piece, but I think we all see that. I mean, we know, to me, patients, specifically with endometriomas, you're going to treat the endometrioma if it's one that you need to treat or whatever. If we don't do anything, that patient, it's coming back at some point. It's absolutely not the answer alone. So there's 13 randomized controlled trials. This is and 4 in this study. Post-op recurrence determined by imaging or symptoms. There was significant reduction of recurrence with post-op suppression. And I think that's really the key. I mean, yes, we still need to do surgery on many patients. I'm not trying to say we don't. It's just that I think it always has to include, or should often include, some additional therapy. Hormonal management and disease progression, again, 58 articles. There's certainly a significant number that didn't have efficacy, right? So if it's not working, that's a whole nother story for reason for surgery. But for those, the 17 to 34% had return of symptoms after completion of treatment. But that's not a surprise either. Many had, again, prolonged positive effect. But even with same story with medical therapy for, a short period of time isn't the answer either. I think it's, more chronic suppression kind of thing. Just again, always about assisted reproduction, and then almost done. I just thought this is IVF, treatment, does that worsen, symptoms? Does assisted reproduction, doesn't appear to really worsen pain, doesn't increase the incidence of recurrence, only small effect on endometriomas, but deep infiltrating disease may progress with some stimulation. But overall, treatment, doesn't appear to be, necessary, and just proceed with the IVF. And obviously, especially with small endometriomas, et cetera, we try to leave them alone. But, again, just surgery alone, probably, it doesn't solve that pathogenic mechanism of endometriosis. Does that, like, yes, we're excising disease, but why are we saying like only those areas that we excise? You know, we know it's sort of goes against it. Just those areas are the only one, you know, then we're done with it. So medical therapy is considered first line for most women with endometriosis to improve the symptoms, but, you know, but also it helps planning adequate timing of surgery with assisted or assisted reproduction, and certainly to prevent post-surgical recurrence. I think it's really key. So medical therapy used in many different ways. But again, the choice and the approach is all about the age of the patient, the pain, there's, you know, what's their symptoms. Clearly surgery has benefit and is effective in treating their, you know, disease, no question. But, you know, the question is, you know, to me is just, again, is it enough alone? And I think it's depending on the patient. Generally speaking, we should try to always add, you know, some suppression along with that. And like I said, I think as I started in the new world, you know, when we have non-invasive testing, right? And, or, you know, especially let's take, you know, patient with some mild, you know, if you take the young patient with dysmenorrhea who, you know, we're now testing, we're saying, hey, you have endometriosis. Does that mean we right away operate on them all? Or are we going to, you know, or do we go a different path with that? And I think, you know, without any other evidence, I think of significant disease, I think I'm going to say we probably, that group, are going to end up going with suppression, you know, more, but you know, but the jury's still out. So thank you very much.